Thank you very much. I want to thank the organizers for inviting me. I just want to show you a little bit about where I come from, and I hope for those of you who have not visited Rochester would come sometime and visit us. I don't have any association with pharmaceutical industry, and so I don't have any disclosures. The objectives of my talk today are the challenges of patients with IgG4-related fibrotic disorders, to recognize the various manifestations of these IgG4-related disorders, to recognize the diagnostic challenges, recognize current thoughts on the pathogenesis, recognize the challenges of medical therapy, and as Dr. Wander asked me, to give you an idea about IgG4, whether it's the cause of the disease or it's a result of the disease, and I'll give you my thoughts towards the end of my talk. I want to start with a patient that I saw in the last few months, an 81-year-old physician who developed spontaneous onset of asymmetrical swelling of his legs. CT of the abdomen showed a periaortic mass suspicious for retroperitoneal fibrosis or malignancy. There was a lymph node in the groin which was biopsied, and this was reported to be reactive and thus negative. A PET scan was done which showed some low-grade uptake in the retroperitoneal region. It was thought that this may be a slow-growing lymphoma, and the patient was advised that we should watch it and repeat the scan in 6 months. During the scan, they found there was a nodule in the thyroid. Incidentally, the patient had past history of diabetes insipidus, which had developed in the past year, and an MRI of the head that had been done was negative. This is a CT scan. As you can see, that there is a very significant periaortic shadow, and on an MRI, this lit up very nicely. Laboratory tests revealed a high ESR and CRP, but a positive rheumatoid factor, hypergammaglobulinemia, with IgG being quite high. IgG4 was done, and it was also increased to 571 milligrams per cent. This is a biopsy of that periaortic mass, and as you can see that there is a lot of fibrous tissue and a lot of inflammatory cells. If you look at the pattern of the fibrosis, it seems to be in a whorled pattern, and if you look under the microscope at a higher power, you start to see that these are all inflammatory cells, which are mostly T cells, some B cells, and some plasma cells. When they did staining of these cells, they found that a lot of these cells stained for IgG, and further staining revealed that this was IgG4. In addition, that there was venous phlebitis in the same tissues. So this is a reflection of the positive staining for the IgG4 plasma cells. So the diagnosis we made was of IgG4-related disease, and we'll talk more about this. So what is this IgG4-related disease? It's a disease of unknown etiology, and it's characterized by tumor-like lesions in various organs with a lymphoplasmacytic infiltrate enriched with IgG4 positive plasma cells and fibrosis. We don't know the incidence of this condition because it has not been studied in any significant epidemiological way. The incidence in some reports of male and female is quite equal, and then there are in some situations where there is predominance of males. The mean age is around 59 to 68 with a range of 42 to 79. Now, this disease has been recognized over the last 15 years Initially, when the Japanese workers were studying autoimmune pancreatitis, but since then has been found to affect literally all organs of the body. Autoimmune pancreatitis can occur in 2 to 6% of patients with chronic pancreatitis. It presents as a painless pancreatic mass and may be associated with other manifestations like diabetes and may have increased IgG4 levels. Lymphadenopathy is very common. Close to 80% of the patients with autoimmune pancreatitis have this. Most of the time it's asymptomatic. Histology is very characteristic, as I showed you earlier, and extremely responsive to steroids. Sclerosing cholangitis occurs in these patients, and it may occur in 70% of the patients with autoimmune pancreatitis. It's difficult to distinguish from primary sclerosing cholangitis or cholangiocarcinoma. It's rare without pancreatitis. Histology is critical in making the diagnosis. Occasional patients do have elevated IgG4 levels, and these patients are quite responsive to steroids. Salivary gland involvement has been reported, common in 40% of the patients with autoimmune pancreatitis. There is enlargement of the lacrimal and salivary glands. Again, the histology is similar, and there is low frequency of antibodies in these patients. They are also responsive to steroids. Retroperitoneal fibrosis, like the patient I'm showing you, it's a small subgroup of idiopathic retroperitoneal fibrosis. Clinical picture is very similar, and there is a higher chance of these patients having other organ involvement. Now, these patients develop periodontitis, can have disease in the lungs, pleura, renal disease, as well as in literally all organs of the body. Now, what are the criteria for the diagnosis? Dense lymphoplasmacytic infiltrate is very essential. Storiform pattern of fibrosis may be seen, and then obliterative phlebitis is quite characteristic. People have discussed, argued, and come to some conclusion that IgG4 counts in the histology slides. If it shows 30 to 50 cells per high-power field, it's quite characteristic. And others have discussed the possibility of IgG4 and IgG ratio, with IgG4 being positive in about 40% of the cells. Now, this condition has been given many different names. It all depends upon which subspecialist is seeing these patients. But a group of people got together and felt that the best way of describing this would be to call it IgG4-related disease, and that makes most sense. Now, there are two aspects of this condition. One is, if you look at it, that there is fibrosis, and the other is that there is IgG4 infiltration in the tissues. So the question really comes down is that these two have to be related somehow. Now, if you look at why does fibrosis occur, fibrosis is a natural healing process which occurs in the body. Anywhere where there is injury, there is release of local cytokines, infiltration with effector cells, and these cells develop and produce fibrogenic material which gets deposited as fibroblasts and ends up in fibrous tissue. Now, there are many cytokines which are involved in this whole process. It's not a very straightforward, simple thing, but the basic thing is that there is fibrogenic effector cell which leads to development of the fibrosis. And this fibrosis occurs in all the organs that we know of. Now, this process occurs in patients who are IgG4 positive and also IgG4 negative. So patients with pulmonary fibrosis will show this type of a pattern. Patients with cirrhosis may also show this type of pattern. Now, interestingly, recently there has been more and more interest in genetic factors playing a role, and several different gene mutations have been identified which seem to influence some of the fibrosis that is occurring in different tissues. This is very preliminary, and then a lot more work needs to be done on this. Now let's look about the other molecule, the IgG. IgG molecules are the most abundant of all the immunoglobulins in the blood. IgG4 constitutes about 5% of the IgG total. Slight increase, less than 2 times normal, can be observed in about 5% of the population. There are patients who are lacking IgG4, and some of them lead a pretty normal life, although there have been few patients who seem to have some infections. The role of IgG4 in that setting is not very clear. It's possible that IgG4 plays a role in reducing inflammation driven by complement-fixing antibodies, or in chronic antigenic stimulation like helminth infection and in patients who have allergies. This particular immunoglobulin seems to be driven by type 2 cytokines. Now, this IgG4 molecule is very unstable. It can lead to Fc interaction with other IgG4 molecules and can lead to what is called an FAB arm switch, and I'll show that on the next slide. This leads to a monovalent FAB preventing cross-linking with other immunoglobulins and immune complex formation. It also has very low affinity for C1q and Fc receptors. So this is a cartoon of a normal immunoglobulin molecule. And as you can see, there are 2 light chains, 2 heavy chains. They bind together by disulfide bridges, and this molecule remains intact as it circulates. In the situation of IgG4, when you look at it, there is a problem in the hinge region. One, that there is 3 amino acids missing in the hinge region in IgG4 compared to IgG1. Also, that there is a substitution of a proline with a serine, which has led to prevention of disulfide bonds developing. And this kind of leads to these molecules not binding the 2 heavy chains with each other. The result of that is that there is a FAB arm switch. As you can see in this cartoon, the 3rd molecule that you see is made up of 1/2 of the molecule of the first one and 1/2 of the molecule of the second one. And this type of molecules seem to be unique for this particular immunoglobulin. Anti-hinge IgG4 antibodies have been found in very small amounts in healthy donors and in blood donors. In certain diseases, especially in rheumatoid arthritis, the incidence is much higher. In pre-RA patients, it was almost 4%. In patients who had arthralgia, 13%. In patients who had early rheumatoid arthritis, close to 19%. And then those who had established RA had 16%. So it starts to raise a question that antibodies to the hinge region are playing some sort of a role here. Now, it's interesting that the anti-citrullinated protein antibodies that are seen in rheumatoid arthritis, majority of them are of the IgG4 subclass. So that kind of tells you that there is a chronic immune stimulation which leads to the development of these antibodies which are of the IgG4 subclass. So basically my thinking is that there is a process that initiates damage to the tissues. The healing process occurs leading to fibrosis, and that IgG4 is more of a side event rather than a main event. And since this IgG4 can occur in other conditions also, it looks more like it's the result of chronic stimulation rather than the primary cause. So now, let's get back to our patient. This gentleman, he was started on treatment with 40 milligrams of prednisone. In 3 months, a CT scan showed marked improvement. He did not need desmopressin anymore because his diabetes insipidus disappeared. His inflammatory markers were normal, and his IgG came down to close to 111. At this point, he was starting to show some cushingoid features, so we started him on mycophenolate mofetil. Now, this is X-rays of the CT scans done before treatment and after treatment, and you can see the marked reduction in the periaortic fibrosis that occurred in this gentleman and its response to the steroid therapy. So what are the other things that we use for treatment of this condition? Corticosteroids seem to work the best, but because of side effects, but because of some comorbidities, like a patient who's a diabetic or insulin dependent, we try to avoid steroids if we can. Mycophenolate mofetil, methotrexate, azathioprine have worked very well as steroid-sparing agents. Rituximab is used if we are unable to achieve what we want to with these other drugs. Surgical intervention needs to be thought about, especially in patients who have urethral obstruction, or if there is venous thrombosis, there is venous obstruction. Sometimes you have to do a bypass to relieve the edema of the leg in some of those patients. So surgical intervention needs to be kept in mind depending upon what the patient is suffering from. So, IgG4 disease, I just reviewed with you some of the difficulties that these patients present with, because the biggest diagnostic challenge is there a tumor underlying? And without a biopsy, you cannot make this diagnosis. At the same time, a lot of pathologists are not very comfortable reading IgG4-related pathology slides. So that kind of becomes a challenge for the clinician. You need to kind of recognize that IgG4 disease can occur in any part of the body, and this includes a dura mater in the pituitary, like this gentleman had, in the thyroid, eye, lungs, you name it, it occurs. Treatment initially is very easy in terms of starting them on steroids, but a lot of these patients are resistant to therapy, and that is where the challenge comes as to what do you do next and when do you do it. And in addition to this, the problem is that a lot of these patients, the disease reoccurs. I've had one patient whose disease came back after a 21-year interval, several patients who the disease came back in the 10 to 12-year interval, and these are patients who have completely responded to therapy and have been disease-free for that period of time. So my opinion is that this IgG4-related disease, IgG4 is a marker